I'm Susan Branscombe. I am a recovered food addict. Today on Food Addiction, the Problem and the Solution, we have a special topic panel session involving three experts. The topic is eating disorders and food addiction. What are the similarities and what are the differences? So today with us, we have Dr. Marty Lerner, Amanda Leith, and Esther Helga Gudmundsdottir. Welcome.
Thank you.
Thanks, Susan.
Look forward to getting started. I'm going to introduce you and your companies, and then you'll get a chance to talk about the work that you do. I'll start with Dr. Marty Lerner. Dr. Lerner is the founder and CEO of Milestones in Recovery's eating disorder program, which he started in 1999. Dr. Lerner is a licensed and board-certified clinical psychologist at Milestones in Recovery, and Dr. Lerner is a professional treating food addiction and eating disorders where anorexia, bulimia, and other eating disorders are treated. In his book, A Guide to Eating Disorder Recovery, Defining the Problem, Finding the Solution, he outlines the nature of the disease of food addiction and how to recover. Dr. Lerner has specialized in the treatment of eating disorders since 1980. Milestones has a beautiful facility in Florida which specializes in eating disorders. His website is milestonesprogram.org. We'll put that in our podcast notes. Next, we have Amanda Leith, owner and director of Shift, Recovery by Acorn. Amanda launched Shift, Recovery by Acorn in the spring of 2019, opening an exciting new chapter in the 25-year legacy of Acorn Food Dependency Recovery Services. Amanda began as a member of the Acorn team in 2015, and she identifies as a recovering food addict. Amanda is a certified food addiction counselor, an advanced relapse prevention specialist, ARPS, with a background in drug and alcohol addiction counseling and group facilitation. The Shift website is a very simple foodaddiction.com, and we'll put that in our notes. And last but not least, the owner of this podcast, Food Addiction, Esther Helga Gudmundsdottir. Esther Helga is a well-known pioneer in the treatment and education around food addiction. She resides in Iceland. She is founder and director of one of the first food addiction treatment programs in the world, MFM Food Addiction Treatment Center in Iceland. In 2017, Esther founded the InFact School, the first school in the world to train and certified food addiction professionals and counselors to treat those suffering from the disease. Those completing the training are qualified for certification by the European Certification Board, as well as from the U.S. National Addiction Professional Certification Board. Listeners who might be therapists, anyone specializing in drug addiction treatment, can get this certification in food addiction counseling at the infactschool.com, and classes begin in May and September. So a lot there to cover. I had to briefly summarize it. You folks are pioneers and really well known in the treatment of food addiction and eating disorders. So let's start in the same order. Marty, do you want to spend briefly just talk about your work at Milestones and the facility?
Sure. First of all, thank you for having me on the panel. So as was stated, I've been working in the field of eating disorders, and I would include food addiction for maybe more years than I really want to acknowledge. In any case, so part of what I'm involved with is treating eating disorders at a residential level of care. And what we'll be talking about today is delineating the differences and similarities between what we'll call eating disorders and the professional language or nomenclature and food addiction, and also making the distinction between eating disorders, food addiction, and weight disorders. All of these entities, which we'll be discussing, will have a lot of overlap, but also a lot of distinct characteristics that set them apart from each other. So my work has been more in the area of treatment during the last few decades, but had started out being in the field of medical research brain chemistry, and so on and so forth under the umbrella of looking at the neurobiology, for lack of a better description, of
Hmm.
appetite and weight regulation. So that's a little bit of a Reader's Digest version of my history.
Great, thank you. Amanda?
Thanks, Susan. Thanks so much for having me on this podcast. So, as you said, I work with Shift Recovery, who has been around for over 30 years now, solely treating food addiction. And we have intensive inpatient and outpatient treatment programs. And our treatment is based off the model of drug and alcohol treatment. We treat the addiction of food exactly the same as drug addicts and alcoholics, which is where I started my career, treating drug addiction and alcohol addiction. We do in-person programs in Florida and in Vancouver. We're about to do our first one in the UK in May. We also do virtual treatment programs with a pretty rigorous aftercare program. As a matter of fact, I just finished 14 days of treatment here in Florida. And yeah, this is an amazing topic to be talking about. And I think it would be great for so many of us in these two worlds to be connected rather than separated. So I'm excited to talk about it today.
Wonderful. Well, welcome. Esther, go ahead.
Yeah, I just want to thank you, Susan, for you doing this with us, and I thank Amanda and Marty Lerner as well to be here with us on this topic. It's we have been discussing this for a while, all of us in one way or the other, I think, and I think it's time really to have the discussion. What's the differences in treatment for these two things, or is there a difference? And because I think now, as we approach more recognition for specifically food addiction, there's going to be need. Well, what are we going to do about it? And I can see the need in the world of different kind of professionals. Okay, what are we going to do? And but what I consider a problem for us that are working in the field of food addiction and eating disorders as well, some of us, is that most people that are coming into the field are coming from the diet industry or the health industry, and not the addiction industry. And so there is little understanding, in my opinion. I may be wrong, yes, and on the aspect of what is the essence of treating the disease of the addiction part.
Mm-hmm. Yeah. Well, I want to welcome you all again and thank you so much for taking the time to do this. This is an important topic, and thank you to Milestones in Recovery and Shift for the sponsorship of this episode. Let's dive into some questions. I want to start, Marty, with you. You wrote a great article addressing eating disorders and food addiction. Can you tell us what the listeners would need to know? What are eating disorders? What is food addiction? And how are they different and similar?
Yeah, let me preface my comment by saying that we too, Milestones, look at all eating disorders under the umbrella of being an addictive illness. And from a medical perspective, we look at it as having components that have to do with both the biology of the sufferer, as well as the nature of the person and the environment with which they have developed this or were born with this disease. So that said, the article that I wrote really was an attempt to explain to the reader that there is a distinction, but also an overlap, which I'll explain in a minute, between all the formal language of eating disorders and the informal language of what we're calling food addiction. And so if you look at terms like anorexia and subgroups within that, types of anorexia that have to do with, restricting or compensatory behaviors of restricting and then exercising or any variety of other behaviors to limit weight gain or lose weight, bulimia, binge eating, and compensatory behaviors, uh, binge eating disorders, and what we're going to be talking about in terms of food addiction. The distinction really is much less an issue than recognizing that all these have common denominators. And if you were to look at the current definition of what a substance use disorder is and look at each of those criteria, you would find, I certainly have found through the years, that people with all of these disorders, with only a few exceptions, meet all of the criteria that have been established for what used to be called an addictive disease and now is being referred to as a substance use disorder. So I think that's going to be part of the discussion. I'll end
It
with
is,
this
yeah.
comment, and that is not all people that are, for instance, bulimic or binge eaters or food addicts are overweight, and not all overweight people are food addicts. Not all food addicts suffer with bulimia, anorexia, and so on and so forth. So making those distinctions are important, and recognizing that the poorest measure to diagnose food addiction, or for that matter, an eating disorder, is what someone looks like or what they weigh, which is
Mm,
the same argument I would make for appearance being the defining definition of an addict or an alcoholic.
right. Yeah, for sure. Yeah, Amanda, I'd like you to weigh in on this one as well. Food addiction, eating disorders. I'm not sure I knew this, but Shift, it sounds like, focuses just on food addiction and not eating disorders. So if you had somebody that came to you that had what you thought was an eating disorder, you might refer them somewhere. But if it's food addiction, you would recommend Shift.
Yeah, thanks, Susan. I agree very much with what Marty's saying, and I think there's such a fine line between all of these three. We talk to Marty's got much fancier language than I do, but we kind of talk about them in a person that's struggling with weight, a person that's struggling with emotions, and then an addiction. And depending on what category you're in, and it's incredibly important that you're diagnosed, if you will, properly, so you get the right treatment. However, I rarely have well, I can tell you this, in the last 10 years, I don't think I have anyone that's come to me that I've said, oh, you don't have an addiction, you only have an eating disorder. I haven't seen that.
Hmm.
So I think there is for me, we really want to look at the whole person. And, there's such a big proponent to treating the physical part of the disease and the emotional mental part of the disease. And I think absolutely, whether it's eating disorder or addiction, you need to treat both. I think the difference comes in is there is different parts, like someone that really struggles with restriction of food might struggle with a weighed and measured food plan, but those are just pieces of a treatment plan. So, Susan, it is true. We solely focus on people that have food addiction. And I've never had anyone come to me that is only an emotional eater, has an eating disorder, and doesn't have addiction present. So, yes, it's true. That's what we focus on. And everyone that comes to us is both, as far as I can see.
Yeah. Esther, do you want to add anything?
Yeah, I can agree with both of you, Amanda and Marty. And in my experience, I have the same experience that I rarely do I see people come in that do not have an addiction, but that is like the core. The addiction is the core, and quite often it develops from having some kind of a scare about weight or appearance or something in an earlier year, as a consequence of that, developing kind of eating disorder behaviors that can become addictive as well. And I see that in a lot of ways, in a lot of different ways with my clients, as we struggle through. The ones that obviously have severe food addiction plus severe eating disorder, those are the ones that have the hardest time. And I see that they need much more support. They need longer treatment, real long-term treatment,
Yeah.
to get a handle on the both of these. So yes, I absolutely agree that we are usually working with both.
Yeah, it can be confusing though, because eating disorders, I think of compulsive overeating, I think of that as more of a behavioral kind of thing, a psychological kind of thing, but then it can be addictive too, you know? And so just I'll throw it out to the panel. Is food addiction an eating disorder? And it sounds like eating disorders, there's overlap with food addicts. Are they ever separate? Just anybody that wants to address that.
Well,
Yeah, I'll go ahead.
yeah, I just want to have a short input here. I do get people that are more food addicts than having the psychological difficulties of an eating disorder. And what I see is, for those people, it seems to be more, there seems to be more clarity, and it's an easier road often, because they just have one substance. They don't have the psychological difficulties that develop off of the eating disorder.
Yeah, Marty?
If I can use a analogy, if you looked at the term alcoholism or drug addiction, there, even in literature that dates back to 1939 and 12-step programs, there are subgroups of patterns and symptoms. So you have, for instance, an alcoholic that's a daily drinker and has a physiological dependency on alcohol and requires some medical intervention, and there are some complications to their drinking. There are other people that can go to a 12-step program and don't need that intervention because they may be heavy social drinkers that have crossed the line, but they're not as physiologically dependent, meaning going through a life-threatening withdrawal when they stop drinking. So they could be episodic. So food addiction likewise comes in lots of flavors in those patterns. The common denominator is a sensitivity to certain food substances, as well as a loss of control. That's a given across all addictions. However, when you're looking at the work that I'm involved with, I see more severe cases of food addiction / overlap with eating disorders where people have co-occurring issues. They may be diabetic. They may have cardiovascular disease. They have a mood disorder, usually acute depression. They may be suffering from thoughts of wanting to end their life. They may be self-mutilating in order to deal with some of the trauma and pain. And so the level of care is varied within these groups across all addictions. Same thing with drug addiction. There's a difference between someone that is addicted to Valium or Ativan or Xanax and needs medical supervision because the detox can be life-threatening, and someone that's been abusing cocaine, but the route of administration is, not the same as smoking crack, let's say. They may be able to go to a 12-step program and with support be able to stop and then stay stopped if they work that 12-step program. So it's a hierarchy of acuity from my world that I look at.
Yeah, Amanda?
I would just add I look at it from a place of different stages of the disease. And I think, just like Marty said, depending on what stage we're in, is depending on A, how many symptoms we have and how much treatment we need. And I
Hmm.
think all of these pieces that we're talking about are symptoms of the primary disease. And again, depending on where we are in the cycle, in the stages of our disease, and that doesn't have anything necessarily to do with age or how long we've been in it. There's so many parts to it that that's why it's so critical, I think, that we look at the whole person and based on who they are, as opposed to saying you have an eating disorder or food addiction. If we look at the whole person, how is their disease showing up in their life? Then we create a treatment program based on that. And I think it can look I know it can look very, very, very different in different people, even if they have the same primary.
Hmm. Yeah, I know in your work, Amanda, you've talked about primary versus secondary as eating disorder, primary, addiction, secondary. Um, I think of a food addiction like I think of alcoholism or drug abuse as a brain disease. I think you'll all agree. I see you nodding. When I ingested alcohol, it set up a dopamine response in my brain, just like when I ate sugar, it set up a dopamine response so that I wanted more. I got more. And so I set up it was a physical allergy and a mental obsession, as we say. So, but eating disorders, let me ask you this, Marty. You've got somebody
Sure.
that comes in that has, maybe sexual abuse trauma in their past and they're eating because of that, or they're restricting heavily because of that. They're anorexic, they're throwing up, bulimia, maybe something like that. But they're not addicted. So if you treat her or him, in that eating disorder, then and they're not addicted, then they should be treated, right? They should be able to be treated. Is that right?
Not quite. I have to say that what Amanda was alluding to is that she's never met a food addict that didn't have an addictive, issue, illness. And I'd have to say there are very few exceptions. The only exceptions I've ever met are adolescents that have been dabbling in restricting and dieting that crossed the line where they got into it. And like a light switch, if you intervene quick enough, they may have a complete remission or they may not develop into another form of eating disorder until much later in life. But aside from
Mm-hmm.
that, the glasses that I view my patients are from an addictive lens, and they all fit those criteria. I mean, I've
Yeah.
been, like most of us in this podcast, we've been yelling from the top of the mountains for 20 years or more about this, and we're not, the people that treat these disorders, eating disorders, don't have a clue about addiction, in my experience. They're looking
Hmm.
at it from a psychiatric training model, which,
Yes.
I admit I came from until I went to treatment myself, for alcohol and drugs, and then,
Hmm.
saw it through another pair of glasses. So all of that said, there is another piece to this. And so if all eating disorders slash food addiction is an addictive brain disease, then you need to also look at the fact that a lot of us who have suffered with this or treat people that suffer with this watch them. I call it switching deck chairs on the Titanic. So they
Yep.
go from overeating to dieting to finding exercise, to finding, the latest, a weight loss du jour, whether that's, a pill or an injection or a surgical procedure. And that will work for some people with weight disorders. It does not work for an addict. And to me,
Right.
addiction's a generic term. So a lot of people that suffer with food addiction come to milestones with coexisting issues that need
Hmm.
to be addressed.
Yeah. Yeah, for sure. Amanda and Esther, you want to weigh in on this?
Just want to say one thing, Susan. A couple of minutes ago, and I might just have heard you wrong, but you said that you've heard me refer to, eating disorder as the primary and addiction as the secondary. Other way around. For me, I'm always looking at addiction as the primary and what are the symptoms because based on that. So I don't know if that matters, but I just wanted to clear that
Yeah.
part up. Yeah.
Yeah, thanks for clarifying it. I know I've heard you before a couple of times, and in our interview, you talked about normal eater, emotional eater, and addictive eater. And if somebody is eating out of emotions only, they're not an addictive. They don't have the brain that goes to addiction when they start eating. If you treat the emotional part of this, they should be able to lose weight if that is their issue, right? I mean, I've heard you talk about that.
Susan, can
Looks
I
like
just,
Marty's got his.
yeah,
Yeah.
I'm sorry, I just wanted to edit a comment, if that's a way to put it. We do see people that have trauma and emotional triggers to eating. However, there's something very important. It's the same analogy with alcoholism. Uh, um, until you stop the addictive behavior or the ingestion of the substance, you cannot hope to achieve any positive outcome treating the secondary issues. It doesn't matter whether the trauma came first or second. What matters is an alcoholic must stop drinking in order to do the work in a 12-step program or in treatment or in
Mm-hmm.
therapy. And likewise, someone with an eating disorder or food addiction with trauma or depression or what have you must stop the pattern of eating in order to deal with the underlying emotions
Mm-hmm.
propelling it.
Yeah. Yeah. Amanda?
Yeah, I was just, when I was going to start speaking, that's exactly what I was going to say. What Marty said is that for me, and this might be off, I think it might be less about, is it coming from an eating disorder or an addiction? We cannot treat one without, like, you have to treat the physical as well as the emotional and mental at the same time. So if someone's purging or restricting because of an eating disorder or an addiction, we can't work on the mental, emotional while they're still purging or restricting. It's not going to work. We have to treat it all together. Um, and that's what I'm so passionate about. Like, I just sometimes I think, and I'm sure it is very, very important, and maybe I overlook the terms, but I think that's the miss that we have, that we're just
Mm-hmm.
trying, again, as practitioners, many people are just treating one symptom of the issue, and it doesn't work long term.
No.
I've never seen it work.
No. And we'll talk about abstinence, complete abstinence. And one question I have here, and Esther, I'd like you to address it around the Yale food scale. And Marty says it well in his article. Just like with drug addiction, not all drugs are addictive. Just like with food, not all foods are addictive. I've never been addicted to celery, but I was addicted to M&Ms and pizza. And, so as far as the Yale food scale and addictive measures, and this is where it gets complicated, I'm addicted to food. Well, have you ever eaten too much celery? No, it's certain foods, right? Esther, talk about that.
Well, I think you hit on a really, really sensitive vein here, which is what is, where do we approach addiction? What would be an abstinence, and where are the boards or the lines between? Talking about the Yale scale, that is the first and only validated assessment tool that we have to validate food addiction. What it does say to us is that at least 50 to 20% of people that do take it show signs of food addiction. And I think that is probably catching the people that are really late final stage people in the addiction. I don't think it really catches the early stages so well, but that's okay. We can deal with that, and to see that if we count it together, it's quite a lot of millions that do have that disease. And yes, as we talk about what to eat and what not to eat, there are some food addicts that would overeat celery. And that's one of the problems we have. This is why, for us that have been in the clinical work for so long, we see that people overeat anything and everything if that is where they're at. Not everybody will do that, but so this is why when I am asked and participating in the consensus conference coming up in May, we will talk about that. We were being asked about the word food addiction. Should we use that going on and forward? And I was the only one there that said yes. I think even if it isn't really, the best explanation, it is what explains that it is food substances that we are addicted to, and eating behaviors that we are addicted to. And that can be eating too much celery just as much as different kinds
Too many
of
M&Ms.
M&Ms and such. For sure.
Yeah. Let's talk about abstinence, and we're going to talk about recovery, and then we are going to talk about the consensus meeting in London in May. When I was recovered from alcoholism, I had to stop drinking, and then I had to get to work. And when I got into this program I'm in for food addiction, I had to put offending substances down, and then I had to get to work. Again, continuing to see the causes and conditions, which were a number of things, and that's what people do in recovery. But talk about abstinence and how important that is, that if you're going to recover from this disease, that you have to be abstinent. Talk about abstinence. Anybody can jump in.
Let me just make one comment about that. It's really abstinences, plural. In my experience, and I'm sure you all will kind of agree, one size doesn't fit all. However, there are some substances within food, particularly as a rule of thumb, the more processed the food, the more addictive it may be. And then to Esther's comment about volume, sure, you can eat quote unquote non-sugar, non-flour, and abstinent approved foods, but the volume triggers insulin dumping. And so the mechanism is to affect brain chemistry and the reward system and the craving and all of that. So volume can do that, just like someone that has a drug addiction can substitute for an opiate, they could substitute a benzodiazepine, a Xanax. It's not their drug of choice, but it'll do. And likewise, if you're not doing sugar and flour, and the only thing around is celery, you'll do that to the point where you get the same kind of a response. So anyway, that's that piece. What I have found is that I haven't seen many people that meet criteria for food addiction that can handle sugar or its many different forms. And then if you look at the hierarchy under that, I would say might be flour or white flour. And then under that, there's some people that refine that more into, well, grains or wheat or, artificial sweeteners. So the list can be very comprehensive. And my bias is that you start with the basics and then people, I don't want to say by trial and error, but they need to identify their trigger foods. For one person, it may be volume as much as it is sugar and flour. For another person, it could be sugar, flour, volume, and then you can go down the list. But you have to start somewhere. So when you have a group of people that you're treating, you have boundaries around the food, and then by trial and error, right or wrong, we get them to recognize their own truth. Last thing I'll say is in recovery, I have found personally and professionally, there are some people that are in 12-step programs that have had their issues primarily with alcohol that can handle taking a pain medication and there are others that can't. And there are some food addicts that can handle, brown rice, and others that can't. So you
Hmm.
really have to individualize this over time. So what my food plan might look like at day 1 might be somewhat different, at day 400.
Right. Yeah. Amanda, I'm going to set you up for this question. I know you want to weigh in here. I came to Shift and went through the intensive in May of 2019. That was when you first began leading Shift, and Phil Wardell was there. And it was an incredible experience. And one of the things that you do at Shift is list all the foods that you've ever binged on. And I listed
Mm.
35. And there are
Oh,
probably more, but that 35 foods I've binged on. So talk about this topic and address maybe if you want what Marty has said.
Yeah, we can get so lost in this debate about food plans,
Yeah. Yeah.
and I think it's a lot of smoke and mirrors, to be really honest. And what I can say, and I'm just echoing Esther and Marty. In my experience, with food addicts, middle to late stage food addicts, the three most common things that I see that every one of those middle to late stage food addicts need is no sugar, no flour, and a weighed and measured food plan. That's what I see. All
Hmm.
the rest of it, artificial sweetener, grains, caffeine, all the rest of it can be individual. And but those three things seem to be shared among these food plans that are successful with people.
right.
And I think that if we are, in my opinion, if people are abstinent first and then very quickly are working a rigorous program that involves emotional, mental, spiritual healing, recovery, um, I actually see people having to do, I don't know what the proper word is, but the food, adding different things that they're Okay, let me back up a second here. When I see people struggling with their food and they are doing those three things, weighed and measured, no flour, no sugar, if they're struggling with the food, what I see is that they're not doing the healing around the mental, emotional, and spiritual work.
Mm.
If they do that, the majority of the time, I see people in long-term recovery if they're doing those three things. I want to be clear. I'm not saying that there are some people that can't avoid those other things, but I rarely see people in relapse when they're truly abstinent doing those things. I rarely see people in relapse because of the food. If they're truly abstinent, it's because of the other part of the work.
Other
So they
stuff.
can't be separate. They
Yeah.
have to go together, but it must start with the physical abstinence.
Yeah. Yeah.
Amanda makes a
Marty?
very important point, and that is that let's look at stage 1 recovery versus stage 2 recovery. Stage 1 is getting abstinent, no sugar, no flour, weighed and measured meals. We're all on board with that because that covers the waterfront with volume. People with eating disorders, in my experience, regardless of flavor, either over or underestimate portions. I've seen anorectics will measure a chicken breast up to the nearest neutron. And food addicts, put 6 pounds of bacon and say, well, I'm also doing Atkins, or something like that. But the point is that the therapy can be important, emotional, whether it's EMDR, trauma work, whatever. But I think we're all going to agree the real bias is working a 12-step program because abstinence represents across the board with all addictions, the first step only. And
Yeah.
if you're not working a program of recovery and then doing, in my world, it would be the maintenance steps in a 12-step program
Hmm.
and being in the middle of the herd of like-minded people, your chances of long-term recovery go down substantially. So the
Yeah.
therapy is important, but if I were making a hierarchy, I would say abstinence first, working a 12-step program and therapy third. Sometimes the therapy and the work in the 12-step program can happen simultaneously because some
Hmm.
people have co-occurring psychiatric and medical issues that need to
Yeah.
be addressed.
Yeah. I know Esther agrees with me here, and I think it's agreed among us. I don't want to put words in anybody's mouth, but 12-step recovery is how I recovered from alcoholism and food addiction. And I know Esther believes in it as well. And we talk about the problem and the solution. The solution for me, and I know for others, is a 12-step recovery program. And I have to work at it every day.
I just want to put a little bit into this if we have the space for it.
Yeah.
I just want to say you put it so beautifully, the both of you, and specifically you, Marty, to just see the breadth of what needs to happen. And I think what's wonderful, being in a group with you guys is that we're all on the floor. We're working with people. So we have firsthand experience with what really works and what does not work for people as we go forward with them. So I'm saying, okay, this is the same experience as that I have. And with 12-step work or not 12-step work, it is obvious that when we do, and we've gotten like the Cochrane research with John Kelly and others telling us that the treatment guided 12-step manual work on the model of the big book is what really works the best. And it's not to say that we're not using other methods like EMDR and therapy, like the other kind of counseling methods
Mm-hmm.
and help. Absolutely, that needs to be there. But in order for a recovery to happen, we need to have all of these.
Right. There could be therapy necessary. It could be medication. Marty, I know you want to say something.
Well, yeah, this is a very timely conversation on this topic because there's always going to be the magic pill, the magic solution. And, we've been around long enough to witness, gastric bypass, then gastric sleeve, then Olean, you can, and the diet du jour. And we're going to be looking at semaglutides and other things that are multi-billion-dollar industries in the quote unquote weight loss industry.
Mhm.
And even though I'll just take gastric bypass as an example, there's this thing. Well, we interview people to see if they're appropriate for gastric bypass. That's BS because if you're a surgeon, you're a hammer and everybody becomes a nail. And the problem with that, is that if you have an addiction, I'll use the analogy again with alcoholism. You could take antabuse, you could take Rivia, you could take naltrexone, you could take any one of these, elements. But if you're not ready to stop and you are a true addict, unless you do what the work is entailed, there is no science found an easier, softer way kind of solution. So we're going to see
Mm-hmm.
people that in the short run, just like with gastric bypass or the program du jour, are going to get seduced into thinking they're curing their food addiction and will end up, knocking at our door. And you've
For
seen this with
sure.
gastric bypass because the phenomenon with the data now is showing people that have had gastric bypass will either regain the weight back into their food addiction or will develop late onset alcohol
Yeah.
dependency.
Yeah. I've
So
heard
the
that.
addiction is the core piece, just as we're
Yeah.
all saying. And so there is no quick fix.
No, I wish there was. Ozempic, I mean, that's a very popular drug right now. I wish it was that easy, but we're going to see we're seeing problems with that. But I'm going to ask you a question about recovery. And then we're going to, as we wrap up at the end here for the next 10 minutes um, or so, I'm going to talk about the conference in London and then the DSM. But as far as recovery goes, I recovered from alcoholism using a 12-step program. I recovered from food addiction using a 12-step program. I did not get into treatment. And I think I'm safe in saying that the three of you agree that it is important to get into a treatment program especially if you are a critical level food addict, you're carrying 200 pounds or you're using food in unhealthy ways. If you can, just spend a brief amount of time, each of you, talking about the importance of getting into a treatment recovery program.
I will answer that question in a sec. I just want to add something that I really think is important for people to hear right now
Mm-hmm.
as we're talking about, the different weight loss surgeries and the different drugs that are out there. I actually think treating people with these methods is actually very, very harmful because it keeps people in the addictive cycle longer because we're only treating one of the symptoms, which for many could be weight. And so I actually think that they're very, very harmful. There might be room for them in the addiction treatment world, but we have to be doing the other parts of treatment. And I feel so, so many people that struggle with weight have been at this struggle for so long and tried so many different things. Like, as Marty said, the diet of the day and weight loss surgery. And now there's these new drugs that are out there. And I just see it as being incredibly harmful because, again, it lightens up a symptom for somebody so they're not as desperate. So they stay in that circle of addiction. So I can use that to lead right into treatment. And, as we've all said, it's become very common for people to need to go to drug and alcohol treatment if being in a 12-step program isn't sufficient for them. And for many people it is. And I would really love in my lifetime to see going to treatment for food addiction to become the norm. And it's not in the rooms yet of the 12-step fellowships, and 12-step fellowships are so important. And many of us, I was personally one of them, needed more. I needed more support with my food addiction. I could not get physically sober while I was in the 12-step rooms. And when I say physically sober, I mean physically sober with my food. So I think it is such a key piece to make it more normal, make it part of a normal conversation that people are going to treatment to get support with their food
Esther
addiction.
and Marty?
Yeah, I'm gonna plug in there, Marty. Sorry.
No.
Yeah. So like living in Iceland and having like a small community to view as I've been, the provider of food addiction treatment here in Iceland and connected to the 12-step programs as well, pretty well. I see that how important treatment has been for the 12-step community here in Iceland. And there's two different programs here in Iceland that are blossoming with people coming from treatment. And we see that with other addictions. And I think the reason that people don't have the treatment in their mind is that we have so little of it. There are so few people and places around in the world at this time still, even though it is growing. And I know a lot of impact school students have started doing different things and as well.
Mm-hmm.
But I agree that my belief is, and I see that when people get treatment, some kind of a knowledge base, they get the exercise and being abstinent, having the support, and learning about what it is really that they need to learn to do and change in their lives, what needs to change, then it becomes so much easier for them to understand why they should continue in 12-step work.
Yeah, it's a real jump start, isn't it, Marty,
Yes.
to get into recovery?
Well,
and
it is
treatment.
and it isn't. Here's the contra story. In my world, at the residential level of care, let's just use the terms eating disorders and food addiction or pathological relationships with food and weight as interchangeable. When I started, there might have been 12 quote unquote eating disorder programs in the country. Now I lost count. I know of only 3 that treat eating disorders / food addiction from a 12-step / addictions perspective. So there is something in medicine, we call it iatrogenic, meaning it's physician or professional induced illness, like prescribing Ativan left and right or opiates and all of that, and the doctor creating the addiction. So everybody that's treating this, with the exception of these 3 programs, myself included as one of them, are reinforcing the notion that you can do controlled drinking, except this is controlled eating, do intuitive eating, know that you don't have a brain disease, you have a psychiatric illness, and are teaching people, because they are doomed to have a high rate of recidivism and failure, that they failed. And they haven't failed, they just haven't found the proper treatment. So part of our purpose with this podcast, part of what's happening in London, part of what's happening, in this growth of looking at this from a pair of lenses that are different, is to try to get people to at least consider that this is an addictive illness. And I got to tell you something, when you explain it to someone and show them the criteria of what a substance use disorder is, it's irrefutable. They just
Yeah.
don't know. So it's like finding out you're an alcoholic. It's like this moment of clarity.
Mm-hmm. Yeah. We've spent a lot of time talking about food addiction in this podcast today, as opposed to what's the difference in eating disorders and food addiction. And I think it just speaks to the fact that there's so much overlap, and food addiction underlies a lot of this. So if somebody comes in and says, look, I can't stop eating like crazy volumes of food and then purging, there could be an addiction there, right, to the food, and so it's a little messy and tricky. Would you agree here?
Well, yeah, but you also, I don't mean to be contrary, but some people are as addicted to the compensatory behavior like exercise
Yeah.
or self-inducing regurgitation, or
Right.
taking laxatives. They're still addicts. It's just the substances are in the food, but also in the behavior of substances they use
Behaviors.
to undo it.
Right. Like there are gambling, sex addiction. These are behaviors as well that we know are addictive. And so there
Yes.
are food behaviors, people licking spoons, people, doing a lot of crazy things with food, eating out of the trash can. We've heard it all, right?
Just like smokers
Anything.
who I quit and then they're rumming through the garbage because they don't have any cigarettes left. They're looking for the little,
Right.
if you've been there, you
Right.
know what I mean.
Yeah, that's an addiction. Yeah, for sure. In the interest of time, I want to make sure we cover what's happening in London. I know Amanda will be there. I'm going to set this up for you. May 17th of this year, 2024, is a one-day conference, the International Food Addiction Consensus Conference, which has drawn a lot of attention. There are clinical experience food addiction experts, all of which we have interviewed on this podcast. Dr. Robert Lustig, Dr. Nicola Vina, Dr. Vera Tarman, a lot of people that specialize in the treatment of food addiction that believe in this are attending this conference. And it's my understanding, Amanda, is that it is to get the World Health Organization to look at food addiction in the ICD, the International Classification of Diseases, if I have that right. Why don't you talk about this consensus and what the purpose of it is, what you're trying to gain from it, the group?
Okay.
Yes, Amanda.
Yeah, so you said it very well, and that's exactly what it's for. It's trying to get a consensus among all these different professionals, and it's really not been easy to get a consensus. And so the process has been, and Marty and Esther and I have all been on. There's been little groups going on for the last couple of months of professionals kind of saying their beliefs, stating their case, if you will, and based on that, we're coming up with this consensus. So the idea is that by the time we're at the conference, the consensus has been formed and we have the terminology, and the terminology has been so important because the goal for many people has been to get this into the DSM and ICD so that it can be quite honestly, and Marty and Esther, you might have better words than I, that it can be covered by insurance and it's recognized worldwide as
Yes.
a disease. So my understanding, the latest we have is all the groups are done, all the consensus, the pieces of information are in, and shortly we'll have what that consensus is. And then I think the conference is just basically on celebrating that consensus. Yeah, I'm smiling because, as Esther kind of started this off with what is the consensus, it's, I think, those of us in the trenches of working with people with food addiction, I'll say there's really not very many. And I will say that there's people that say they are, but in my experience, they are not.
Mm-hmm.
And
Don't be shy.
Come on, Amanda, say it.
We're all thinking it.
We're all thinking it. Let's just say it. Hey,
I will just say this.
Yeah.
I'll just say this, that there's a lot of people that I think are trying to soften the blow of this. What we're dealing with is addiction. We're dealing with food addiction. And until the reality is there, we're not going to get the treatment that's needed. And no, I don't know what to say. I know we're editing this, but I'm done. I don't know what to say about that.
Esther, what would you say about the consensus?
Well, I say that it is the first step, and we're far beyond, the issue of what's being set up there. All of us here, we're like 20 years or more into, experiences and knowledges about this disease of how to treat it, while the others aren't. And there's not really anyone doing real treatment at the consensus. There's not. And what I think Amanda was trying to say, we've often talked about it, is that what we do see is that there is treatment, really an eating disorder treatment, which has abstinence plan plus some support, but mostly some therapy, and it lacks the component of treating the addiction, which is the mental, emotional, spiritual part of the disease. And that's kind of what I see, and that kind of worries me, that that seems to be the knowledge base for so many, and we have a different knowledge base, and they don't even know about it. They don't even know about it, and which is hard to take a look at, really.
Yeah.
Hard to
what
see.
What I hear you saying is there's what I envision is a lot of talk about the problem. Yes. And what we talk about in this podcast is a solution. Okay, we know the problem. Now, how do you treat it? How do we fix this? And there are a number of ways to recover. 12-step recovery is one, but I just see a lot of talk going on, and then it's like, okay, now what? What's your action item? What's your next step? Anybody agree with that?
I do.
Absolutely.
And I think there's another dimension to it. There is a socioeconomic investment in each person's territory. It's sort of like what I see at the dog park. My dog stakes out its territory in a very special way. and I sorry, but and
Yeah,
I
no, I
think that
understand.
I think what's going to happen, which isn't all negative, is there's going to be a lot of debate and discourse and whatnot. And you're right, it's going to be more defining the problem than working the solution. And I do think
Right.
if we're all having this thing in common where we have a personal set of experiences as well as professional experiences, we know enough to know that all of us are offering treatment programs of one sort or another that are very similar, if not identical, levels of care that are going to attract people because of other people finding other people. And I think we're working a model of recovery that was so successful and keeps being successful by attraction and not promotion. And I understand
Mm,
about the insurance and all of that, but I want you to consider the fact that most of things are culturally defined at a given point in time. Homosexuality, addiction, no longer using the word addiction. Things that were considered mental illness are not considered mental illness anymore. So
hmm
I'm going to stay on the sidelines and be
Just
entertained.
watch. I'm going to watch virtually. I want to be respectful of our time here. Thank you all. This has been really good. I don't want to stop the podcast without talking about the DSM, though. We talk about the U.S. This is a world, the consensus meeting in London is a World Health Organization. The American Psychiatric Association, the Diagnostic and Statistical Manual of Mental Disorders, the DSM, um, there is a movement afoot to put in to the DSM food addiction as a substance use disorder. And we look at, as Marty alluded to, some of the characteristics of a substance use disorder, like alcohol, like drugs: impaired control, social impairment, risky use, pharmacological criteria, craving. These are all things that are part of food addiction. And there has been a movement afoot, as I say. Any words here of wisdom around the DSM and getting it into the APA's, so that food addiction is recognized and it can be paid for as in treatment. Anybody can weigh in.
I don't hold out a lot of optimism because I know that
Mm.
the subcommittees that are on this are not people that have personal experience with this. So they look at it at best as binge eating disorder, compulsive overeating, and AKA, also known as a process addiction.
Mm.
So they may buy
Okay.
into the brain chemistry, but then, so is video addiction. You know what I mean?
Right.
So
Yeah.
I'd like to say it's got a good
Yeah.
chance, but I think they'll pay lip service to it. That's about it.
Yeah. Amanda?
I agree with Marty. I agree, unfortunately, but I completely agree.
Yeah. Esther? I know you want it in there too. We all do.
Yeah, I actually was there almost a year ago in San Francisco on the APA yearly meeting, and where Slick Gerhardt spearheaded and introduced the application that she and her team have been working on with Nora Volkov there, and I don't know what's going to happen with it, but I think this team that has really been working on it this time is very, very strong,
Yeah.
and the personalities there are very, very strong. So I think I have a sense of optimism. My optimism comes to that it will be added as a research item,
Right.
Mm.
and if that happens, I think that is a big win, because then we can start. It's not going to be thrown out. It
Right.
just will
It's
be. But I think the obstacle, just to say to the end of this, is that these professionals, these psychiatrists, they don't know what the heck to do with all of these food addicts. That's
We
the
know
real
what they
issue
need to
here.
do. We know what
Right.
they need to do. And don't underestimate, we talked about this with Dr. Lustig, Nicola Vina, the food industry, the pharmaceutical industry, big billions and billions of dollars that are lobbying against this.
Yes.
They know about the food addiction, highly processed foods. They know about our addiction to sugar. They don't want to see this pass. So, and our little food addiction group universe, we can't fight that, but we march on, right? We march on.
Right.
So this has been great. Thank you so much, Dr. Marty Lerner, Amanda Leith, Esther Helga Gudmundsdottir. I love doing this work with you. I love doing the podcast, and thank you for joining us, and thanks for the sponsorship. This has been great. I think it'll be a great episode for our listeners.
Thank you for
Thank you,
having us.
everybody.